Okay, why don't we go ahead and start this morning.
All right.
Welcome. It's really nice to have this opportunity to talk to you a little bit about intimacy and intimacy disorder. I'm Mark Schwartz,
And I'm Lori Galperin.
and we really want to welcome you. Just a couple introductory remarks. If you have questions, please feel free to write them in, and then we're going to answer them during the second webinar so that we have a chance to think about them, and hope you'll get all the questions answered. Also, if there's anything you want more of or less of, please let us know so the second webinar we can do that. We're also going to give you an online evaluation, which will be sent out to all the attendees after the webinar if you want CEUs. And then finally, the idea of this is to get your input. So if you have any thoughts that you want to add to this and help teach us something, that would be greatly appreciated. Lori and I have worked together how many years now?
Just over 30.
And we started out working in a trauma program together, which I started after working with Masters and Johnson for many years. And just as a way of introducing ourselves, let me just say that when I worked with Masters and Johnson, the focus was on sexual problems, but it was clear to me that almost all the clients had major intimacy disorder. And so I've been on a quest to try to understand what an intimacy disorder is and what to do to treat it. And that's really what this workshop has been about. After that, Lori and I ran 3 programs for inpatient for trauma, resolution, and dissociative disorder, and addiction. And then we decided to open up our own treatment center, which was Castlewood in St. Louis, and that was for eating disorders. So we've really focused on the co-addictions and the morbidity around trauma, which is addictive and trauma. And in our present incarnation, we eventually moved to Monterey, and we work in a place called Harmony Place, Monterey. And we have a small partial hospitalization program where we see about 15 clients. We see them for 6 hours a day, and they live in apartments. So we've got a sort of a sober living environment where they're given a lot of support, and very intensive therapy where they're seen 3 to 4 times a week, in individual therapy. And what we're really focusing on are individuals who have been able to get under control of addictive behavior through residential or inpatient treatment, and now really want to do some of the deeper work around psychotherapy and then life skills in order to be able to get back to creating a life worth living. We found there's far too many people relapsing in the addictive programs we were running, and so we felt like intensive outpatient was really the treatment of choice. And then we're in this beautiful, lovely Monterey, California, so what could be better? All right, if you pull out your handouts, we sent them to you. If for some reason you don't have them, you can just email us, and we'll make sure you get a link to get them. And if you can pull out your hard copies of that, that would be helpful. If not, we'll go through it a little bit with you. But your first handout is the word intimacy disorder. And so I used that word, and I thought it'd be good to define that in some way. And so what we're talking about is a person who has survived a childhood without safe, loving, consistent caretakers and a nurturing environment. And so what happens is that they lack confidence in their ability to master tasks and feel fearful all the time. So when I'm using the word intimacy disorder, I realized that what we were beginning to recognize was that we're talking about problems of attachment. And I happened to be at Hopkins at the time Mary Ainsworth was there, and Bowlby came in for a semester. I got a chance to spend some time with Bowlby and Ainsworth, and they completely changed my thinking about intimacy and intimacy disorder. So I've been really a student of theirs for a long period of time, and Lori and I went out and got trained in the adult attachment interview by some of Mary Main's people, and that really helped us begin to conceptualize what to do to treat intimacy disorder, which we'll be talking about today. So in our first slide, if you turn to it, it lists Alan Strofe, And Alan Strofe wrote a book a year ago that, as far as I'm concerned, changes everything. And what he did, and many of you are aware of, is that he followed 180 children longitudinally from the time that they were in their mother womb until age 30-something, and tested both them and their family members every year of their life, funded by NIH. And his conclusions are absolutely mind-blowing to me, which is he found that in the families, 40% of the parents who had childhood abuse and maltreatment, that in 40% of these cases, they developed disorganized attachment. Another 30% of the sample that he had really borderline care. Another 30% who had therapy. And what that essentially means is that almost 100% of his sample had childhood abuse. And as he followed them 30 years later, those with physical abuse almost never had a positive outcome as an adult. The vast majority developed disorganized attachment at 18 months of age in the strange situation. And that disorganized attachment eventually related to couple hostility in adulthood, meaning that when we see marital problems and we do all these fancy marital interactions with Gottman and other leaders in the field, that the vast majority of the people who are coming in with lots of difficulties actually have disorganized attachment. And so what we need to be thinking about when we're working with marital couples are how to treat disorganized attachment. And that's what this workshop will really be about. What Strofe found was that there are multiple pathways to similar outcomes, and that change is possible at many points in transition. So it's not that you're preordained from 18 months of age, but a lot of things can happen to change that. But nonetheless, even with all those things that can happen to people, there's a very high probability of great difficulties in adulthood. Of all the long-term effects of childhood abuse, the number one is an adult dissociative disorder. And so one of Strofe's staff led a piece of work which eventually decided that there's a very high probability that if you have disorganized attachment at 18 months of age, as an adult, you're going to end up having a disorder of self or dissociative disorder. So that becomes really important. And it reminds me that there are two books that probably have come out recently that are really helpful in this end. One of them is, I can't see what it is. It's a book called Treating Trauma-Related Dissociation by Kathy Steele, Boone, and Vanderhart. And that's an incredibly helpful book and really instructive. And the other one is Dan Brown's book called Attachment Disturbances in Adulthood. And this was written by Elliott and Brown. And this is an incredibly helpful book and probably will change our field dramatically over time.
It's not a brief read. You have to be committed.
Okay. So Lori, if you can pick up and talk a little bit about what Brown and Elliott's idea for secure attachment is.
I will, but I want to go back somewhat. Okay, I'm good. I guess I want to say that no one's perfect and no one should have to be perfect. So one of the things that we often deal with in the client populations that we work with are expectations by the individual, by the client, of themselves to be something that's actually not human, something that would be more perfect than a person is actually meant to be. And a lot of our clients come from family systems in which there wasn't a lot of room to make mistakes, or perhaps there were room for mistakes if you were the child, but then they looked at their parents and how hard their parents might have been on themselves and how hard the parents drove themselves, and internalized that philosophy with regard to themselves as well, even when the parents didn't mean for them to internalize that message. So I think sometimes the reason people don't look back is they don't want to fault their caregivers, which makes sense. I mean, family loyalty and membership is meaningful, but it's unfortunate when it precludes being able to look at how one got to where one is and the issues that were unresolved by prior generations that a person is then heir to. Because whatever's unresolved recreates itself in some form or another. And if a person's not allowed to look at things intergenerationally, then you just feel as though it's all you and you could have done things differently, and you don't see the forces that conspired to constrain your choices. And if you don't see those, then you don't get to free yourself from them and create the actual possibility of free choice and greater options in life. So I think the attitude that I think of that some clients find useful is, I have a feeling that that what a parent would want for their child at the deepest level is something positive. And for that, we all have to heal wherever damage was done originally. And so in actual life, sometimes those systems are orchestrated around shame, and there's kind of an injunction on looking at things that are painful or things that are less than perfect. So rather than blame anyone, I think a person just has to look at what are the issues in families that aren't able to get resolved, not because it's anyone's fault, but just because there isn't the time, or there aren't the resources, or maybe there's not even the courage at the moment to contend with what would be necessary to face in order to really make changes. And so, you know, with all due compassion, can a person go back and look at what he or she inherited, both for better and for worse? So in doing that, sometimes an assignment I like to have people do is to think about, well, what are the necessary and sufficient, you know, kind of minimum daily requirements for a child to not just live, but thrive and flourish, ideally. Just a child in general, any child. You know, I tell them sometimes, look at a little kid at the mall when you're at the mall, or think about your little cousin who's 5, and just think, what's the minimum daily requirement, you know, for a child to thrive? And then a person usually comes up with a list, you know, and the list often includes things that are unusually insightful. And then I find it useful if a person can then go back and look at which ones of those they had on a consistent, reliable basis. And sometimes that tends to be pretty illuminating. And as I often say, no one escapes childhood entirely unscathed, despite everyone's best intentions. So everyone could be so well-intentioned, and still there would be areas where deficits come in because of unresolved issues from prior generations. So I really love in the book that Dan Brown and Daniel Elliott have put together, their ability to conceptualize briefly but powerfully and here's where I have to go to my glasses, what they've called the 5 primary conditions that promote secure attachment. Because I think when you think about childhood and you think about things that create later struggles, later pathology, later mental health challenges, there are things that happen that really are unfortunate because those things are too much and they overwhelm the resources, often not just of the child themselves, but they overwhelm the resources of the attachment environment. So things happen, and it's not that things happen so much as there is an adequate amelioration for what happens in real time available. Again, not because members of the system might not wish it. So there are things that happen that are too much, but then there are also things that don't happen, and that's the backdrop. And so if things happen that are too much, if things are not lacking that are important and essential to ameliorate it, there's not a lot of residual. And so that's why people often look at the same experience in 2 different people and look at a different outcome, but you have so many elements that factor into that, that chart the trajectory from the event. And a lot of it depends on what the attachment environment can provide in terms of mitigation and ameliorative experience. So these are more that backdrop. What does a child need to feel a sense of secure attachment? What are the factors that contribute to that? So that when things happen, there's a safe base. When things happen, there's someone that can be relied upon. And ultimately then creating an internal framework that can be relied upon so that the child themselves begins to have the capacity over time and growth to mitigate and ameliorate their own experiences as they grow up and to bring to bear on difficult emotions ways of working with them that are self-soothing and allow resiliency. So just to be able to name these 5 primary conditions that the 2 Dans have identified as promoting secure attachment, I'm just going to go through them. The first one is a felt sense of safety. So not just a conceptual safety, but a felt sense of safety. And they identify the quality and also what it is in the caregiver that allows it to come about. And in the caregiver, it's protection. So when I think about this, I like to think about mammals other than ourselves. You know, I think of like a mother bear with her bear cub. And it's like that caretaker is fiercely protective of its young, as is often the case with mammals. And that creature feels, I believe, a felt sense of safety if things go reasonably. And in us, because we have life experience and brains and ways of becoming influenced over the course of our own life, by the time we have children, it may not be that we're able to bring forth that kind of fierce protection that a baby mammal needs. And so what can happen is that the child may have a parent that's underprotective. And so when things happen, more things happen because there isn't an alert, aware caregiver to be able to anticipate or be able to respond to dangerous or difficult situations with protective action when possible. So there's underprotection, and then on the part of an anxious caregiver, there can be overprotection, such that, you know, if you're a baby bear, I think you have to learn how to get a salmon out of the river. And that means you can't just sit and look at the river. You're going to have that adult bear get you in the river and help you figure out how to catch a salmon so that you can feed yourself from then on. So an overprotective parent or caregiver doesn't allow for the acquisition of life skills in a way that would create a robustness of capacity in the unfolding young. The second feature in terms of creating the qualities that allow for secure attachment is a sense of feeling seen and known. I think it's the thing that everybody yearns for, truth be known, until we become so filled with shame that we still secretly yearn for it, but simultaneously fear it. I think everyone wants to be seen and known, to be truly received. And of course, the quality in the caregiver that allows for that is attunement, accurate attunement. And what would the antithesis of attunement be? I suppose it would be a disharmony, so that a person is either, you know, unavailable to be attuned because they're preoccupied, or the person might feel as though they're attuned but just entirely miss the reality of what's going on in the internal experience of the other. Third would be a sense of felt comfort. So we have felt safety, and we have feeling seen and known, and now we have felt comfort. As a part of attachment security. And what creates felt comfort is the availability of soothing and reassurance. And this is what allows the internalization of affect regulation as well, which becomes the foundation for feeling and dealing. And you note that all of these things are talked about in terms of a felt sense. So we're not just talking about the way in which Western culture divorces mind from body and we think that that's what we had. It's the feeling of it more than it is the idea of it. So number 4, this is my favorite, my personal favorite, if one can have a favorite among things that are all imperative, is that feeling valued. I think all too often in populations of mental health clients, people have had a sense growing up that they were either too much or too little. And again, not because anyone intended to convey that, but feeling too much or feeling too little is about feeling burdensome in some way or inadequate. And the alternative is feeling valued. I remember one time I was in a restaurant in Northern California, as it turns out. It was the kind of restaurant where it was more casual, and there were a lot of children with families. And I was particularly watching this one family and their interactions with their children. And it was so evident, it was palpable, that they just were so enjoying being with their children. Just that of all the human beings on the planet, these were human beings they just delighted to be with, who also happened to be their children, and they didn't feel the need to overly control them or constrain them in some way, or it just felt exceedingly authentic and appreciative. Like all the beings in this interaction felt the joy of being with all the other people. And what alarmed me about the fact that I noticed it was the fact that it seemed, I don't know, in contrast to what is often seen in seeing families out, and how it becomes just so much about behavior and so little about joy sometimes. And so this sense of being valued, what is the caregiver behavior that allows for it? It's expressed delight, that far from experiencing the child as burdensome or, oh God, one more thing to be dealt with, the child is just a source of delight for the parent. And you can imagine what the self-esteem of a child that has been viewed as a delight is in comparison to the average. And then finally, felt support. Felt support isn't codependency. It isn't really caretaking. It isn't leaving the person to their own devices. It's actually being able, I think, to follow the inclinations and interests and unfolding of the person in front of you, and to facilitate their exploration in the ways that would allow them to become more and more themselves, more and more the unique being that the seed that is them was intended to grow, that can only grow them. So real support, unconditionally, for the exploration that allows a child to develop into the most essential and fulfilling form of themselves, as decided by themselves.
Okay, so it's really important that we go into that kind of detail, because most families have not really defined what is an optimal environment for the child. And as we're able to operation empirically be able to do that, it's easier to define what people didn't get. And that's what seems to be the critical factor in the development of these disorders. So what I did for this workshop is I decided to sit down and lay out what I thought were the key aspects of treatment to repair somebody who has disorganized attachment. Let's remind you that disorganized attachment is when you turn to your caregiver for support, and that what you get is nurturing at times, and at other times you get fear. And so your brain is programmed to, under distress, to cling to your parent, or we wouldn't have survived as a species. So the attachment system is a natural anxiolytic in your brain. And when you get comfort from your caregiver, there's a reduction of anxiety. But if your caregiver is abusive or neglectful, then comfort is also associated with agony and pain, and you're creating psychopathology. The result of that is what's called disorganized attachment. And so the $50 million question is, how do you treat disorganized attachment? So I wrote out what I felt were the various components of treatment, and I decided that I'd begin the lecture by telling you what I want you to know. So I'm going to go with the rest of the lecture is going to be about each of these, but I'm going to go through them briefly. If you're multitasking, you might just focus for a little while, because this stuff is pretty complex. And what I'm going to say in the next 5 minutes is probably what I want you to take out of the workshop. The first step is for a person to have a cohesive narrative. And in the cohesive narrative, what we're looking for is that their thoughts and feelings and actions are consistent with one another. And so if a person's unable to feel, then we're probably going to be talking about somebody who's more likely to have a pattern of avoidance in their pattern. and a person is overly feeling in a more hysterical kind of way without thinking in a cohesive way, then you're probably going to have someone more on the preoccupied side. Preoccupied is when you cling, avoidant is when you pull away. So when under stress, either people move towards, they move away, or they move against. And we're talking about people who both move towards and move away when we're talking about disorganized attachment. Second criteria are family loyalties. In this case, as Lori has already mentioned, many people come in very loyal to their family, idealizing it, and they think, even if they're locked in closets and burned with cigarettes, that their childhood is relatively normal. That would not be a cohesive narrative because the actions are not consistent with the conclusions. And so what we have to do is something to begin to deal with having a ability to look at one's past without rose-colored glasses. On the other hand, if you're filled with rage and anger, and you spend a good 15, 20 minutes talking about how much you hate your dad, then your anger causes you to be preoccupied, and you're likely to have strong preoccupied attachment. Third is encouragement of one's unique self. As Lori has said, that if someone has not taken delight in their child's uniqueness, or wanted them to be a chip off the old block, and not fed the differentiation of the child to be who they're meant to be, you're probably going to get a disorder of self. And so our work in dissociative disorders has helped us enormously work with, in a Gestalt sort of way, with kind of integrating parts of self that are split off, and in a very psychodynamic way, to find the parts of self that a person dislikes and hates, and begin to help them begin to change that system. And there we do much more internal work around self, borrowing from Winnicott, Kohut, and now Dick Schwartz. Fourth is working with self-compassion, compassion for self and others. And there are, I think the biggest problem therapists encounter are people who come in with really structural deficits where they hate themselves. And Jeffrey Young has talked about schema therapy, where a person comes in and just is filled with self-hatred. And the question is, where does that come from and how do you change it? Cognitive therapies are legendarily unsuccessful in changing people's self-beliefs. And so what one has to do is go back to where many of these beliefs about self were implanted and begin to change them. We'll talk about how to be able to do that. The next criteria is called involving in the adult attachment interview. And that's basically a role reversal, where the parent takes care of the child rather than, where the child takes care of the parent rather than the parent taking care of the child. And the result of that is you become codependent. The way I think Lori says it is that your blueprint of how you love is written in childhood. And if the way the blueprint was written is that you take care of others, even your brothers and your sisters, then that's how it gets defined that love is written. And so as an adult, you'll probably repeat that in some way. And so we have people who are really good at giving, but not so good at taking. Next is dealing with grief. Clearly, Bowlby's book on loss pointed out that people's inability to deal with grief is really what psychotherapy has been about. And there's so much mourning that needs to take place about losses in one's life. And if you're unable to deal with that, you're going to have adult depression or anxiety. And so grief work is always critical to working with one's attachment. Next on my list is the state of mind to attachment. And in that case, we're looking at the attunement between the client and the therapist. As we all know, the ability to be able to relate to your therapist is really critical. And if someone comes with avoidant attachment, then they're going to be avoidant with their therapist. If they come with preoccupied attachment, they're going to cling to their therapist in a dependent sort of way. If they have disorganized attachment, they're going to go back and forth. So if you have a healthy therapist with good boundaries, you can begin to repair the attachment system. And so, one of the things that's so important about internal family systems therapy is that Dick Schwartz spends a lot of time working with the therapist on their own ability to form healthy boundaries. And that turns out to be really critical for repairing the attachment system. And then finally, the one that's probably most neglected and really most interesting and important right now to me is metacognition. If you followed Peter Fonagy's work with reflective function, what he's begun to say is that what children need more than anything is to be able to go to their parent when they're having things that they don't understand in the outside world, and learn about themselves in relation to other people and themselves in relation to their environment. So if the teacher in school has been, abusive, and the child comes in and says, why is he acting this way? And the parent says, what did you do wrong today? It's an invalidating environment, as Marshall Linehan says. And the result of that is begin to have difficulty with metacognition. And so a lot of the new kinds of therapies around mindfulness and a lot of the work that came out of Menninger's clinic on metacognition or mentalizing therapy is beginning to look at the way people think about thinking. And what that turns out to be, in a simple kind of way, is the ability to remove oneself from the situation and be able to see it clearly. So if a person says something to you like, I realized that my dad was really abusive and mean, and I hated him for a lot of years. But as I got to be an adult, I began to recognize that he fought in Vietnam, and when he came back from Vietnam, he was really badly injured mentally and was drinking heavily. And so as I've got older, I've begun to recognize that a lot of things that he did were the result of his own neglect and abuse and from the war trauma that he experienced. Well, that ability to apply metacognition and look at that with some perspective is the beginning of moving towards what Mary Main calls earned secure attachment. Earned secure attachment is when at 18 months of age you probably had disorganized attachment, but a number of things have happened, usually therapy, that allows you to begin to get perspective. And you might say, well, aren't we just naming what we always do in therapy? And the answer is absolutely. But by beginning to define metacognition and the variables related to it, it allows you to delineate what happens in the psychotherapeutic process, which is effective or not effective, and get really tight with that. And so as we get later in the lecture, I'm going to be talking to you about some of the newer work around metacognition. And if you want to read about it from a very sophisticated, you might look at Peter Fonagy's book on the development of self, and you'll see a tremendous amount of really interesting data on children that will allow you to begin to apply that to adults. Okay, so that's really what this workshop is going to be about, which is how do you help a person who has an attachment disorder develop earned secure attachment. Now let me just say one last thing about this before I turn it back to Lori. When a couple comes in, they'll define their, they have a problem with anger, they're having a problem with money, they're having a problem with the children, they're having a problem with an affair. But rarely is the problem that they present the problem. It's the manifestation of the problem. In a similar kind of way, a person comes in with an addiction. It might be alcohol, drugs, food, sex. Rarely is that the problem. It's a symptom of the problem. And so what we tend to do in psychotherapy is we over-focus on the symptom, but we don't look at the problem underneath it. As an example, in our eating disorder clinic, we worked with anorexic, bulimic, and compulsive overeating. But when I tested 100 individuals on the adult attachment interview, what I found was that 100% of them had disorganized attachment. And so I began to define success in treatment as moving them towards earned secure attachment rather than just getting under control of their food-related behavior. And so the same thing is true with alcohol and drugs, that the real goal is helping people develop the ability to use other people as a source of an anxiolytic, for a source of comfort. One of the clients who left our program said, when I'm with people, I don't feel a sense of connection. They like me, I can take care of them, but I always feel alone. And if that's true, they're probably going to relapse. And so our real problem is helping people form a true connection with other people as a resource to comfort themselves, which is now what we're defining as secure attachment.
I was thinking that very thing. I was thinking about how the basic principle is that addiction of any kind is about using a substance or an object as a source of comfort rather than turning to other human beings. And if you think about it, it's like if you're an alcoholic, you turn to liquor. If you're a drug addict, you turn to drugs. If you are a workaholic, you turn to work. And it's a way of numbing the feelings, mitigating the feelings, burying the feelings, distracting from the feelings. And of course, some distraction can be useful, but a lifetime of distraction is an addictive way of life. And then, of course, there's socially sanctioned addictions, and then there's socially looked down upon addictions. But nonetheless, an addictive way of life keeps a person from becoming fully human and from having the depth of intimacy that is possible to have. A lot of the clients that I've seen over the years, who many of whom have been trauma survivors, but also many of whom have just experienced deficits in the attachment environment, or who have experienced role reversal such that, you know, other human beings imply obligations and being drained as opposed to being recharged and revitalized. So even people from homes that look somewhat healthy sometimes, as Mark was saying, are very good at themselves giving, but they haven't had much of a internalized template to be able to receive, and they're in grave danger of becoming therapists. Okay, yeah, that was intended to be a joke. So so in order not to have an addictive way of life, one has to ultimately come back to relationship as the vehicle for healing. And if you think about it, a lot of times it's the rupture in attachment later in life that causes a person to go into an addictive cycle. And so while we can do relapse prevention from now till doomsday, it can't possibly hold unless we also facilitate the person coming back to the ability to utilize human relationship, both within the self and between people and in groups, to be able to work with adapting to life situations. So I don't know, if you sort of drill down to the very soul of dysfunction, it's probably disconnection from the self. When parts of self get exiled and a person wants to be exclusionary and not let some of their parts into the system, where are they going to go? And lack of connection among people, because as long as everyone has to act like everything's just fine, there's not going to be real connection. Intimacy is about self-disclosure and self-revelation and the possibility of an empathic response from another being that knows what it's like. And that is really the healing agent. And then when one is disconnected from self and from others, it's pretty hard to feel a connection to a higher power, to God, to the universe, to whatever one sees as being representative of the creative force. And so being disconnected in all these ways, life is not very fulfilling and life is lonely. And at the root of so much of mental dysfunction and dis-ease, as many say, is that reality, the disconnection.
So a new field emerged called Developmental Psychopathology, and most of you are aware of the journal. It's an incredible amount of work has been accumulated. And the idea of this is that, as Schwartz pointed out, there are these life is feel like a set of dominoes. The first thing affects the second thing, affects the third thing. So everything that's happened to your life has brought you to where you are now. And so if you come in and you say, why are you anxious? Or why are you an addict? It's the answer the person comes up with is a false attribution, because it's everything that's happened affects the next thing. And so if you have disorganized attachment at 18 months of age, then you're probably going to be bullied in school, and then the teachers are going to reject you, your grades are going to go down, and everything follows from that in some way. And what trauma is where the developmental demands sequentially are so great that you can't accommodate in a Piaget kind of sense. So we have to think of a robust definition of trauma. So Dick Schwartz calls these burdens. And burdens are a good term, because a burden means that both the events that have occurred in your life that have affected you, things that have affected your family, and perhaps intergenerational burdens that you were brought into that affect you in some ways. Now, we kind of got on the wrong track, because 30 years ago, we began to recognize that trauma was the key element in a person's developmental trajectory that led to psychopathology. And so we began to work on treating trauma like many of you have. And what we eventually realized is that, yes, you can treat PTSD effectively. You can take a score on a PTSD test and give somebody therapy, and they can come in with a high score, and they come in, and when they leave, they have a low score. But that doesn't necessarily make them happy. It doesn't necessarily make them have a reasonable life or without depression or anxiety. Because trauma is a little bit like addiction. You can stop a person from drinking or drugging or whatever their addiction is, but that's the first stage of treatment, as we all know. Underneath that is, what's the next stage of treatment? And the next stage of treatment, obviously, is beginning to look at this developmental trajectory in some way and help them form connections with self and other. And so we do trauma work. It's a necessary component of treatment. And what most of us have discovered is that people get remarkably better as you do good trauma work. However, it's not sufficient. And so we struggle with what comes after that. And that becomes repairing of the attachment system, which we'll be talking about, which includes oftentimes family work. And then finally, it doesn't necessarily mean that person has the skills to be able to live in the world, because they have structural deficits. What they didn't learn at age 2 or 4 or 6 or 8 or 10 results in permanent deficits, both in brain development and in behavior and in thinking and feeling. And so now in doing intensive outpatient work, we can begin to work with them in their interaction with the outside world. And so I've become very interested in the life coaching element of this, because as a therapist, you see somebody for an hour in their office, you can't see what they're really like in social situations or work situations, and you really can't see the deficits, and oftentimes the client doesn't even know themselves. So you don't know what the goals are. So I had to have some way to be able to assess that and then eventually begin to ameliorate it. And so we're going to be talking to you about dealing with life skills and be able to talk about the concept of sober and life coaching and structural deficits. So stage 1 is getting under control of the trauma, the addictive behavior, anxiety and depression. Stage 2 is beginning to do the deeper work around attachment and relationship with self and disorder of self and relationship with others. And then the third stage of treatment is always looking at here and now and helping the person develop the ability to be able to master their environment and begin to interact with people and feel effective and powerful in their work with the world. This next slide, just to point out to you, it looks kind of weird about these two people interacting, but I just want to add that when we're talking about trauma, we're also talking about enmeshment, that infusion, that more and more of the data is showing that enmeshment and fusion can be as severe as locking kids in closets and burning them with cigarettes, horrible trauma. And that, what we're talking about there is the interference of mastery that comes from individuation. So when you're thinking about neglect, make sure you understand it both dimensions. Oftentimes we have an idea you can't love too much, but there's healthy love and there's unhealthy love. And a parent who is getting their needs met by taking care of the child is fusion. And a parent whose focus is in allowing the child to separate and individuate and become who they're meant to be is a person who is allowing their child to become. And I think so many of our clients get confused as their parents seem to be over-loving them in their mind. And the word love is a very complex, tricky kind of term.
Uh-oh, that's an interesting time to turn to me. Well, I was thinking about it this way. A few minutes ago, I was talking about the inability to derive connection, soothing, amelioration, uplifting from a connection with another human being. And therefore creating fertile ground for addiction, where one attempts to derive those things from a substance or an object. I think the problem is that sometimes we actually treat other people as objects, and that's actually what you're describing when you say there are different kinds of things that are called love. So you can love someone as an object, which means that you need them to be a certain way. Or you can hate someone as an object, actually. Often in intergenerational issues that occur in families, often there's a child that's like the chosen child, and this child is somehow seen as a positive object. And sometimes there's a scapegoat, and the scapegoat is the negative object. And I say object because the person isn't exactly seen in the fullness of their true being. They're seen through a filter of some past unresolved issue that gets projected. And, it could be that a child looks like a parent, or the child looks like the other parent, or the child has the same temperament as a parent or a different temperament. It could be that a child reminds a parent of their own parent, with whom they either have a close relationship or a very distant relationship that's conflictual and that's unresolved, and that they thought they dealt with by moving halfway across the world. So, as I say, whatever's unresolved will repeat itself, typically in veiled form. And because it's in veiled form, the person who's the recipient of whatever good or bad projections doesn't really know that it's not about them. The problem then is a person who's treated as a good object often becomes narcissistic, in the sense that they need to be seen as a good object by a lot of people, because that equaled love. And they don't know that that's actually what they internalized and what they're now seeking. And it's never quite enough, because it isn't fulfilling. So it's like in a bottomless cup. It has to keep getting filled over and over again. And a person who's, of course, treated as a bad object that can never quite deliver adequately comes to feel as though something is essentially wrong with them, like they're defective in some way, which we have a name for that. We call it shame. And it's as though the person comes to feel that they were created with some crucial aspect missing that was needed, or they came with like an extra part that was too much, and therefore they can never quite get it right. And of course, a person who feels that way has very little self-esteem, although they may be quite functional and quite achieving, because they're constantly trying to achieve the thing that will make the difference and allow them to feel a sense of being okay, not realizing that no achievement will yield that, because it's an issue around attachment, even under the issue around self-esteem. And the person on the flip side of it too, no matter what their achievements, there's still not a resting place, not a place where they just can be and where that's adequate.
Okay, let's turn to section 2, attachment and intimacy. Most workshops I attend are great in the conceptual end, but they don't give you many tools to go out and change the way you do therapy. So each slide I'm going to try to talk about what we actually do in the room and try to give you kind of tools that can be more effective in your practice. So the first one is that I'm defining disorganized attachment, which is that fear activates the attachment system, but the primary attachment figure is the source of fear. And so the importance of that is that the research shows that if two people are securely attached, they're probably going to have a really good marriage. They're not the couple that come into our relational therapy. What usually happens is that a person with avoidant attachment, finds somebody who's preoccupied, they get together and they create one hell of a mess. And so we work with them as a couple, ignoring their attachment patterns, and that is necessary but not sufficient. And I think what Gottman showed us is that our failure rate with couples is just enormously high, and what to do about that. So what we did is we developed a different way of working with couples, which was that we see a husband and wife or same-sex couple, and we come as a pair. So I work with one individual, Lori works with the other individual. And we work with them in a Gottman, Susan Johnson kind of way and work with them on their relationship and give them homework assignments and such in a traditional marital setting. But then in the room, we spend a second hour working with them on attachment work. And so if he has avoidant attachment, I'm going to be working with him one-on-one on the avoidant attachment. If she is preoccupied, Laura will be working with her one-on-one on the preoccupied attachment. But we do that with a spouse in the room. And the reason for that is when we open up a lot of the intense work from the past, we want the couple to be able to leave. And once we open that up, to be able to process that as a couple, and that's the definition of intimacy. In other words, in vivo intimacy is sharing deeply with the other something about yourself, both affect and cognition. And so that tends to work very effectively. So as a couple, we'll usually see them for 2 hours a day, once dealing with traditional, and then once really working with the attachment work. And we're finding that it is a very powerful way of working with a couple. Now, when we use these words secure, avoidant, and ambivalent, not all of you are going to be familiar with that. So I just gave you Hazen and Schaefer's idea of this, which is secure is I find it easy to get close to others. Avoidant is I'm uncomfortable being close to people. And ambivalent is I find that others are reluctant to get close as I would like. And so you can think that in a very simple way as looking at yourself or looking at others. And then I also gave you I thought the best questionnaire if you want a quick and dirty measurement of attachment with couples when they're coming in. The Experiences in Close Relationships questionnaire is probably the most reliable and valid measure. And it has a lot of ability to predict what happened early in life. But the gold standard still remains the adult attachment interview. And to do this, we spent 10 days in training intensively, and for 8 hours a day. It's very, very intense training. And a lot of the wisdom that we're giving you today really came out of our training with the adult attachment interview. And even if you don't get trained in it, the questions themselves are incredibly valuable. It's worth spending some time later looking at that and thinking about those in your original assessment. It's a very potent measurement. As a joke, Lori and I came back from that training. We were sort of blown away by how much we learned just by being able to talk to somebody in the way they use language. And we had friends over for dinner, and they said, "Oh, tell us about the workshop." And so, I said to my best friend something like, "Well, what do you think about how your relationship with your wife was influenced by your relationship with your mother?" And the guy looked at me, and his eyes got really big, and he said, "I don't think it's affected me at all." His wife was over there going like this. And as he began to talk about that, I realized that this is a very dangerous tool because I could tell too much that I didn't want to know. And so it's one of these things that it's a very powerful instrument that leads you to be very, very good at assessing and diagnosing people's attachment patterns very quickly.
Now no one will want to have dinner with you. Just want to say.
All right. So you can turn to the romantic attachment. I want to say something about sexuality, which was in a study that was done on attachment. They looked at adolescents who had avoidant attachment. And this was remarkable. The girls that had avoidant attachment, they had sex as frequently as the other girls, but they said that when they had sex, they did it more out of pressure from peers, and that they were uncomfortable and that they didn't feel much. That when their partner touched them, it was sort of like, what I didn't get anything out of it. I didn't respond to it in any kind of way. Now that's really valuable for me because as a Masters and Johnson trained therapist, we did all this work around repairing people's sexuality, but in truth, it wasn't really about sex at all. It was always about attachment. And so we were dealing with avoidant attachment that was manifesting itself with sexual symptoms. In a very similar way, the preoccupied or the anxious attached ones were incredibly passionate. They loved hugging and kissing. But the problem was not with sexuality, it was that they were too needy, they were too dependent. They became fused with their partner and smothered them in some way. And so they developed merger-seeker relationship. The more they needed the other, the more the other had to hold on to themselves and pull away. And that then resulted in a sexual manifestation of, I want sex all the time, the other person doesn't want sex at all. So what I'm saying to you is that in sex therapy, it's a mistake to treat the sexual symptoms. And people always misconstrued Masters and Johnson work as sort of sexual gymnastics, but we never worked just with sexuality. Our primary work was with the relationship and intimacy. But we didn't have the tools back then that we do now. And so sex therapy has now been transformed, and it's really just a simple manifestation of the attachment problem in the bedroom. Okay, so the next slide just talks about these primary conditions to promote secure attachment. And Lori has talked about that before, but we put it in graph form here. And you get the manifestation in couples, which is feeling alone, feeling bad, feeling dread, feeling too much or too little, and feeling like a false self. And so...
Well, okay. Well, let me talk about it in this context. So what I did was I tried to look at, in the original category, it was the caregiver and the child. And I thought, how does that translate into a pair bonding relationship between partners? And tried to kind of extrapolate from the original. So as we look at this slide, I was thinking that the first one, the sense of felt safety, what would be the result first of feeling either under or overprotected rather than fiercely protected by a parent? And it would be feeling alone, that you would feel as though you had to face all possible danger and be ready for it without help. That's what would be internalized. And then I thought, what would you want in a partner that would be the correlate of a fiercely protective parent that you knew you could count on? And I think what people, to me, express so often in relational therapy is the desire for a partner that has their back. As someone once said to me, it's like if you're in a foxhole, you want to know you can trust the person who's in there with you. And that's what you need in a romantic partner as well, that you're going to establish a pair bond with. The second one, the feeling seen and known, I think if you don't feel seen and known, you wind up feeling empty, or you wind up feeling bad, as in defective, inadequate. And what does a person need in a partner in order not to feel bad? I think what you need in the parent is attunement. What you need in the partner is their awareness of you, separate from their projections onto you, which is a harder thing than it sounds like, because in love relationships, there's often the original projections, which are positive when we're in love, and then in the next phase that's about some disillusionment, they're often negative projections. And then when people want to part ways, in this culture anyway, what we usually do is amp up the negative projections so that we can entirely lay waste to the other person, so that no part of us still yearns for them, which is actually unfortunate and probably indicative of a cultural attachment disorder. But in any event, I think what you want is that a person would have an awareness of you and who you are without either their positive or negative projections. They wouldn't need you to be, you know, Prince Charming on a white stallion, and they wouldn't and they would perceive you as you are. Soothing and reassurance. I think what is the absence of soothing and reassurance leads to a feeling of anxiety and dread. There is no felt comfort, and instead there is kind of that perpetual sense of what's going to happen, and when's it going to happen, waiting for the other shoe to fall. And what would be comparable to soothing and reassurance from a parent is, I think you want a partner who's responsive. And often what you get is a partner who either is not fully present, or a partner who wants to fix what's wrong, which feels like an empathic failure. So I think what's needed is a partner who's responsive and who has boundaries, so they don't jump in to fix things for you, and they don't distance emotionally from your struggle, but they let it be your struggle. What would be the result of not feeling valued, of not having someone delight in you, is that I think a person feels burdensome, like too much, like too little, like not worth the time or space, and they shrink. And I think what a partner does for a person is hopefully to delight in them too. And to delight in a partner ongoing, I think one has to remember to see them with the eyes of love, without projections, as you once did. So I think that it's not necessarily that we imbue people with qualities they don't have initially. I think it's initially, by seeing them in a way, it allows some of their finest qualities to come to the surface. And when they're not seen, it's almost difficult for those qualities to re-emerge and flourish. So it's always a bi-directional process. And then what is correlated with the experience of having or not having the ability to get supported for unfolding your unique self. And I use the term unique self as Mark Goffney, the author, uses it in his book on Radical Guide to Enlightenment, Your Unique Self. And I think a person winds up feeling like a false self. Feeling like a false self, one feels that the house of cards may cave in at any point, and one feels like even though they may achieve a lot, it doesn't really accrue into a sense of esteem or a sense of fulfillment. And having a partner who really loves you, not as a narcissistic extension of themselves, so not as an object, so not as the role that you play for them, but having a person see and love your true self, or your most essential self and your unique self, allows it to begin to unfold.
Okay, so if you turn to the next slide, you might be curious about how frequent, what is this? The data suggests that about half of a population is securely attached. Doesn't seem that way, but that's what the data shows. The other half are probably in our practices in a variety of sorts. The disorganized are more likely to be in the addictive populations, the anxious and avoidance in our couples work. And if you look at singles, what you find is that the securely attached stay in long-term relationships, but a lot of single people are in one of these other categories. And the problem is that if you're single, there's a glut of people out there with attachment problems, and so you're going to have lots of difficulty, finding a partner. And so the idea is, for example, if you have an individual who's avoidantly attached, what you want them to be able to do is find somebody securely attached to help repair the attachment system. That's the very best thing that can be done. But most of them are married still, so you end up getting in destructive relationships. So given that fact, so many people seem to be unhappy with the state of being single. Now, we've talked about attachment from a lot of different perspectives. I want to add one other, which if you look at the next slide, you're going to look at and you're going to get a little overwhelmed. So please don't be, because it's really quite simple. The second way of looking at attachment is from Patricia Crittenden, and this is her slide. And Patricia Crittenden wrote a book on attachment that is incredible. And we also did some training with her over time and love her work. And what I want you to be able to see is not see these as discrete categories. And so on the left side are the A's, which are, what you have is the A pattern is the avoidant attachment. The C pattern is the preoccupied attachment. So the A's are avoidant, on the right side are the preoccupied. At the top are the B pattern. The B pattern are securely attached. And what you can see is that there are three components of A and there's three components of C. So when we say ACs get together, what we're talking about is there are different combinations of this in some way. Now, by beginning to think of this in a continuum, we can begin to see that what happens is the ones who have avoidant attachment, which are individuals on the A pattern, they think their cognition is high, but their affect is low. People on the C pattern have very high affect with false cognition. Now, at the bottom is AC, which is psychopathology, and at the top is the B3s, which are really securely attached. Now, you end up getting a fair number of B4s and B1s in your population of single people, and they're the ones who are best to get into a relationship in some way. Now, by using her way of scoring the AAI, it's incredibly helpful, and we score our clients on both Crittenden and Maine's measurements, and it was incredibly diagnostic and helpful to our therapy and led us to the actual treatment. Okay, so I'm going to go through the next slides fairly quickly. I just want to, clinically, what you see with avoidant attachment is a lack of memory for childhood and a lot of derogation about being close to people and not liking therapy at all. And avoidance of getting close, discomfort with closeness, mistrust of others, not feeling much safety. They're workaholics and they're high in achievement, and sometimes they'll come in and they have multiple affairs because they get bored very quickly. On the preoccupied, they tend to be really preoccupied with past relationships. They want to talk forever about their past. They're great candidates for analysis because they can talk for years about their unfinished business with their parents, and it doesn't seem to get them very far. They're heavily into lapses in reasoning, and the most common thing for us in the trauma population are the unresolved disorganized state. And their individuals have what Mary Main looks at as discourse problems, where you'll see in their speech patterns, they don't finish their sentences, their thoughts are very unclear, they're not very articulate. And what Mary Main picked up that is, I think, absolutely incredible is the way people speak is an indication of their cohesiveness with regards to self. You know, good psychotherapy is about integration. Integration one's past, present, and future. Integration of the disowned parts of self, and being able to integrate means that you begin to be more cohesive in the way you think and feel and act. And those are the goals of good psychotherapy. And so what we're trying to be able to do is do that. So in one of my groups, I call it attachment group. We have people do narratives about their life. We have them practice getting a cohesive narrative. And then they'll come in and they'll say something like this. You know, my dad and I were very close. And we'll say, well, what are the indicators of your dad and you being very close? And they'll say, well, my dad worked with me. He was a school teacher, and he worked with me on my math, you know, for 2 hours a week. And so what we notice is that the way the dad was close was instrumental, working with them 2 hours a week on their math, and that they defined that as very close. Now, it's very good that the dad did that, but that's not very close. My dad and I spent a lot of times working on math. And so that's the beginning of avoidant attachment. And so by beginning to see that and help them become metacognitional about that, they're beginning to move towards earned secure attachment because they're able to step back and look at the situation. And the group is incredibly helpful in being able to point that out. So we teach the group more about these principles and then have the group begin to confront and support and begin to help the person reintegrate their perceptions of what happened in their life and make them more reality-based. The result of that is greater cohesion and fresh thinking, better metacognition. And what we see is they do that, their speech patterns change, there's an integration of affect, cognition, and behavior, and their relationships with people change remarkably. All right, so we want to move on now to interpsychic intimacy versus intrapsychic intimacy. And one of the things we realized is that we were working a lot with trauma, and we became much more skilled at working with dissociative states. And so at the beginning, I showed you this book on treatment of trauma-related dissociation. And this is kind of the new Bible of working with dissociative disorder. And that field has remarkably advanced. And it moved from what Masterson used to call disorders of self. And I love Masterson's conceptualizations. And what he says is that people take their internal splits. They're at a civil war with themselves. They hate themselves, and they hate parts of themselves, and the parts of themselves hate them. And there's this internal battle, and all this energy goes to hating themselves, which is not really available for connections with others. And so the idea of this is then integration. And so when we do couples work, we're talking about forming not only a secure attachment with others, but we began to work with forming a secure attachment with self. And that's a prerequisite. You've got to have an I before you have a we. And practically no one talks about how do you facilitate a secure attachment with self. So we're going to let Lori do that.
Yeah. Give it to Mikey, he'll lead it. You saw that commercial. Well, I just have to say something. So earlier you said things in a way that I want to clarify. So talking about attachment issues, it isn't us and them, you know, like we're not all securely attached and finished products and the clients who come to see us are necessarily less so, and certainly not the general populace. So, I mean, it takes a tremendous amount of courage actually to look and attempt to change things rather than just go from relationship to relationship, phase to phase, deciding it's good enough. I mean, to actually inquire into these things. So I find our clients amazing. And I don't want it to sound as though there's some, isn't that great if we had the good fortune to be securely attached originally, because our attachment environment was unusually robust and healthy, and people had had time to work through enough of their own histories to not project it inordinately. But I think that's not typical. And so I just want to normalize the growth and struggle that is, a choice by some. Some people have the option because it's not going to kill them if they don't really explore this and make changes. And other people can't live this life if they don't go where others are afraid to go. And I literally feel incredibly, respectful of that willingness every day. So, you want me to talk about interpsychic intimacy versus intrapsychic intimacy. So, commonly, when people are growing up, they elaborate the parts of themselves that net them love or approval or attention or affection by whoever's love they're seeking and whoever's attention they desperately need. So a lot of times, children accommodate in all kinds of ways that they don't even realize at the time, giving away parts of themselves and downplaying them if they met with punishment or frowns or non-reinforcement, and then becoming more of what it seems like is desired. So by the time anyone reaches puberty, a lot of ourselves, I think, are sort of, as Dick Schwartz would say, exiled. And exiled often means, I think, locked in the deep, dark basement of our awareness. And, we feel like if we never hear from them again, it'll be fine. But actually, within these vital parts that have often taken on a tremendous amount of shame or negativity, and who are unhealed, there's a vitality, there's a portion of our being that's lost to us. So to be able to go back and figure out what it is that we yielded of ourselves in order to, and bargained away for what seemed like safety or what seemed like approval, is really important. So if a person's doing cognitive work and looking at their schemas, if a person's doing behavioral work and changing their behavior patterns, if a person's taking care of themselves in a more dedicated way, whether they want to or not, they're going to hit snags. And the snags that they hit, the stuck points that they get to, are typically indicative of a place where something's unfinished, or something's in contradiction. So let me give an example of this. In dealing with eating disorder clients, a lot of the time, clients who are anorexic often want to be anorexic. and feel some pride in their ability to not need anything, not food really, not sleep really, not help with things, you know, to be what feels like autonomous and not dependent. Not everyone, but a lot. And then if an anorexic has the pendulum swing to the other side of restriction, such that then they're also periodically binging or binging and purging, which starvation will make a person hungry enough to do sometimes, then they consider that often the dysfunction. And when they get back to their anorexia, they feel in control again. But ironically, they might be at their most human and therefore most helpable when they're actually wanting something, when they're not so pseudo-autonomous, and when they actually realize their need for something, even though it feels way out of balance. But typically what it sends them back into is wanting to restrict all the more and need even less. So the problem is the pendulum swings from one end of the continuum to the other. And so most people would say, oh, you just need to get them to a point on the continuum that's in the middle. But actually, if only that were adequate, that would be delightful, but rarely is that adequate. The question is, why are they swinging wildly between attempting not to be human and not need anything, food, people, anything, and just achieve and produce, and the other end of the continuum when they can't do it any longer? Why? What sent them into needing to so overfunction and so restrict their humanity that seems like a way of living when it's only a way of dying? And why do they hate this part of themselves that has needs? And so for that, then you have to do more than cognitive behavioral work. You have to assist the person in asking themselves, how did it get to be that way? So you're looking at their belief systems, for sure. You're looking at their schema, but you're looking at what were the circumstances that gave rise to that. And typically it's not an event. I mean, an event may precipitate something because a system reaches critical mass and then the symptom is manifest. But typically things build over time. So for example, having a person do a timeline where they look back at how they came by certain beliefs, what were the experiences that led you to have that belief? And then often doing EMDR or doing ego state work or doing expressive therapy to be able to have the person go back and provide in some way what was not available then, that would have allowed for them not to get stuck and to begin to move forward from a belief system that may have made sense in the original context, but is actually killing them.
Well, we're out of time, so let me just sort of summarize and get you ready for the second webinar. The books that I would order between now and then would be Alan Stroh's book called The Development of the Child. It's incredibly good. And there's a book for your clients called Attached, which is really, really good. And then Brown and Elliott's book on the attachment disturbances in adults. Those are the three books that I would highly recommend. What we said so far is that we need to repair the attachment system. And by doing that, what we need to do is first get the addictive behavior under control, or the anxiety, depression, or bipolar symptoms under control. Second, we need to begin to do family of origin work with a couple in the system. And in that, begin to do attachment work and help them move towards earned secure attachment. And then third, to do that, one has to do trauma resolution therapies, but that's necessary but not sufficient. And then we have to begin to work with the dissociative features of disorganized attachment and the split off parts of self. And that we use internal family systems, EMDR, expressive therapies, Gestalt work, and other kinds of affect-based therapies, Diana Fosha's work. As we begin next time, we're really going to be focused now on, what do you actually do to repair the attachment system? And Brown and Elliott have this incredible, what they call 4 pillars to repair the attachment system. And we're going to demonstrate a little bit how we actually work with a patient and show you how we do some of that work that they've taught us. In the meantime, if you want us to emphasize anything else, or if you have questions, I hope you'll let us know that, and we'll fit that into the next series of talks. Thank you for joining us. It's been great, much appreciative. And for CEUs, you just need to fill out your evaluations, and we'll make sure you get them. Thank you. Bye-bye.